Hello and welcome to Unstressed. I'm Dr Ron Ehrlich. A theme you are going to always hear on this podcast, one that needs a constant reminder, is sleep. Sleep is, without a doubt, the most important part of the day. Over the last 15 years or so, it's become an important part of our healthcare program in our practice. In fact, I would imagine any health practitioner of whatever persuasion, be they medical practitioner, naturopaths, chiros, osteos, whatever, if sleep is not part of the questions that you are asking your patients, or it's not something you're focusing on, then it's more than likely you're not focusing on it yourself in your own life, because that's how I came to it. I mean, when I realised 15 years ago how important sleep was, something which I'd taken for granted for a hell of a long time, I realised the difference it could make. So, but anyway, the questions are, what is a good night's sleep, and what actually defines a good night's sleep, and what are some of the steps you can take for it to really happen? And the key word here is consistently good night's sleep. Just getting one good night's sleep here and there is really not what it's about. I think getting a consistently good night's sleep will help you build the mental, physical and emotional resilience that you need to face the stresses of our modern world. Now, Anup Desai is the sleep physician that I have been working with for many years. And you'll be surprised to hear the amount of training that goes into a sleep specialist. I mean, many of you may not have heard of this as a specialty, but sleep physicians are a specialty, and the amount of training that Anup has gone through is kind of mind-boggling, really. It also is going to be insightful. We're going to cover some problems later on in the podcast. We're going to take a break in the middle of it, and I'm going to ask you 3 key questions. But I hope you enjoy this interview that I had with Dr. Anup Desai. Welcome to the show, Anup.
Thanks, Ron.
Now, Anup, you and I would both agree that arguably sleep's the most important part of the day, but not everybody sees it that way. Perhaps we could tell people why sleep's important.
Yeah, Ron, sleep is clearly an extremely important part of the day, and it's often a neglected part of the day, or at least in the sense that people don't think of it and realise the importance. We all sleep. We often sleep too little or without good quality. We don't recognise that actually is a key to how we function during the day and to our overall health.
Now, what actually defines a good night's sleep? I mean, people think putting their head on the pillow is enough.
Yeah.
What defines a good night's sleep?
Yeah, no, that's a good question. So a good night's sleep has a whole lot of different aspects to it. So firstly, you need to progress through the different sleep stages. There's a whole lot of defined sleep stages, from non-REM sleep to REM sleep, different abbreviations to describe different aspects of sleep. So we want to see people progress through the non-REM and then the REM stage several times overnight. Then we want to see enough time for sleep, adequate duration for sleep. As a society, we're increasingly sleep restricted for lots of reasons that many of us can imagine, and a lot of people don't get enough time for sleep, and therefore that's inadequate. And then the final aspect of good sleep is not having any sleep fragmenting condition, having a sleep disorder that's disturbing that quality. So there's architecture, quantity and quality.
Okay. Now you mentioned REM, and our audience is a non-medical audience, so just go back to some basics here, REM and non-REM.
So REM is our most vigorous dreaming stage of sleep. It's rapid eye movement sleep. During that stage of sleep, we're dreaming, we're paralysed, where our eyes are moving, and that's why we call it REM, and we're breathing just with our diaphragm, so that all of our muscles are turned off, there's very active dreaming, and the eyes are moving. It's important for memory consolidation in particular.
Right.
Some hormone secretion perhaps is happening in REM, but most important is for memory consolidation, and if you don't get adequate REM, you may find your memory the next day or even the long-term memory is impaired.
Do you have to go through, now that you said the non-REM, that's the initial stages of sleep, is that right? Are they the early stages of sleep, the non-REM?
Correct. Usually a personal cycle between starting with non-REM, stages 1 and 2 of non-REM, and then moving to stage 3.
Yep.
And then they go to REM, and that whole cycle takes about 90 minutes or so.
Right.
And then that will happen 4 or 5 times overnight. So the correct sequencing is non-REM, REM, non-REM, REM, non-REM, REM, non-REM, REM. As we age, the proportions of non-REM and REM change. Kids in particular get a lot more slow wave sleep or one of the non-REM stages. Then as you get older, you get less of that with time.
So everybody has, according to age, everybody has a different requirement. What is that range? I mean, young kids, I've now got a granddaughter who's 2 years old. Children, how much should they be sleeping?
Yeah, so sleep duration changes with time, and kids in particular need a lot of sleep and a lot more sleep than they often get, and then adults need a little bit less. So as an adult, we need about 7 to 9 hours sleep per night.
And that's over 18 years old, would you call an adult? Or?
Yeah.
Yeah, okay.
So what they've done is they've done studies where they've asked adults to stay in sleep laboratories for weeks at a time, and they've let them sleep as much or as little as they like. And what they found is for the first few days, maybe a week, they were sleeping about 10 hours a night. They were catching up on all the so-called sleep debt. Then they averaged about 8.14 hours. So we're thinking people need about 8 in general. However, there is some individual variability, and that's why I've said 7 to 9 is roughly the amount of sleep an adult needs. Kids need more. So like a 12-year-old will need about 10 to 11 hours sleep.
Right.
And as they get younger, they need even a little bit more. So durations do change with time. The amount of sleep is really quite important, and that's the bit that gets restricted in general at a society level.
And you also mentioned the sleep architecture. Now, that duration's one thing, and getting enough of that is important. When you say architecture, what did you mean by that?
So the architecture is that progression between non-REM and REM, non-REM and REM. And some medications will disrupt that, will reduce, for instance, REM sleep, and others might increase slow-wave sleep. So the exact effect of changing all those different stages of sleep is not well understood, but we do recognise that people with good sleep quality do progress quite nicely between these different sleep stages.
And is it important to get uninterrupted sleep? Like, we're meant to get 7 to 9 hours sleep a night.
Yeah.
To go from point A to point B uninterrupted, is that
not absolutely uninterrupted. It's normal to wake up overnight. So many times, in fact, your brain wakes up and has these sort of micro-arousals that you're not aware of. But what you may be aware of is a so-called macro-arousal where you wake up completely to full alertness. Maybe at that point you might go to the bathroom, or maybe you'll just be aware of restlessness in bed. It's normal to wake up 1, 2, even 3 times overnight. But the real issue is whether you fall asleep again quickly. So if you wake up transiently, maybe go to the bathroom and then just drift back off to sleep, then that's not a problem. But if you wake up and can't get back to sleep, that is suggestive of a condition called insomnia, which is its own sleep disorder in itself.
Yes, what defines insomnia? I mean, everybody has, sometimes they go through stages of having trouble getting to sleep, but how do we define when it becomes a problem?
So insomnia is very common, as you've mentioned. We've all experienced it, and it can be acute, it can be transient, it can be chronic. So the main insomnia issue that is clinically important is probably the chronic insomnia, which is essentially defined as difficulty falling asleep or difficulty maintaining sleep. So difficulty falling asleep is when someone may take more than 15, 20 minutes, 30 minutes to fall asleep. Difficulty maintaining sleep is they may wake up and can't get back to sleep, which is what I was just talking about.
Yeah.
Or they may have frequent arousals overnight where they just wake in and it's happening too many times and it's disturbing to them. Or they have what we call early morning awakening, where they sleep from, say, 10 p.m. to 4 a.m. but then can't fall asleep after that. So that's early morning awakening. So they're all different types of insomnia, if you like. The other important thing about insomnia is it's associated with daytime distress. So if a person's waking up overnight and they're not bothered by it during the day, it's not really an issue. But if it's happening overnight and the next day they're fatigued, they're tired, they're obviously disturbed, that they're not getting good quality sleep, then that's what we call insomnia. And we just find chronic insomnia is when it's occurring several nights per week over a period of time, say 1 month, 2 months or 3 months.
And how common a problem is it?
It's very common. I mean, we've all had it acutely. In terms of chronic insomnia, it will depend on the population. It's a bit more common in the elderly, but it could be anywhere from 10 to 25% of the population.
Wow.
Again, it just depends on how we define it and the degree of daytime disturbance that we associate with the definition. But essentially, it'd be easy to call it, 10, 20% of the population.
And what kind of percentage of the population do you think are getting enough sleep? Going back to just our basic sleep. How big a problem is not sleeping well?
Yeah, no, that's a good question. So in terms of duration, I think only a handful of people are getting adequate duration. So probably at a guess, 20, 30% are getting enough hours that they need.
Wow.
And they're not getting enough because of the obvious things: 24-hour operation of industry and services, work commitments, family commitments, social commitments, all these gadgets we now have. People use them in bed, their phones, their iPads, their laptops. So always there's a way of reducing the time available for sleep, and that of course leads to sleep restriction and not enough duration. Kids have many activities, they're staying up later for various things. So I think that's really quite a common problem that's unrecognised and easily addressed when we start to educate people. In addition, there's a whole group of sleep disorders, of course. Now, obstructive sleep apnea can be as many as 25% of middle-aged men.
Wow.
10 to 15% of middle-aged women. And that's based on older prevalence data. And now the populations have changed with more obesity, and it actually could be a lot higher.
Wow.
Insomnia, we talked about, could be 20%.
Yeah.
To be honest, I mean, from a sleep perspective, it's hard to imagine there are many people that are ticking all the boxes.
Right. And you also mentioned that when you have a deficit, if you haven't been sleeping well, you've got a lot of sleep to make up. Yeah. It's like putting money back in the bank.
Yeah. In fact, it's a lot of people think they can manage with small amounts of sleep, but the reality is they can't. So what studies have shown that is if you, say, sleep for 5 hours per night for a week, your performance, say, on tasks that we might measure, reaction time tasks, memory tasks, sort of verbal tasks, keeps deteriorating throughout the week and goes up. And then even if you have 1 or 2 nights of catch-up sleep, say on a weekend, because a lot of people will sleep restrict during the week, try and sleep in on the weekend, that's not enough to catch up those 7 to 10 hours of lost sleep during the weekday. So their performance does not improve to baseline levels. So a catch-up of 1 or 2 nights is not enough. That sleeping on the weekend is not enough. And if anything, I think that creates more problems, because what it then does is it shifts your sleep rhythm to later in the day, because you start to maybe go to bed later, wake up later, and that's what we call a delayed sleep phase. And by the time you get to Monday, when you need to wake up at 6 or 7 in the morning again, your whole sleep rhythm's moved further to later in the day, and it's even harder to wake up in the morning. And I think that's one of the reasons why people get this sort of Monday-itis, where Monday is just a bit of a disaster in the morning. They feel really groggy.
You know, I heard the study where people who sleep 3 to 4 hours a night, they know they're not getting enough sleep, but it's the group that sleeps, say, as you said, 5 or 6 hours or 6 hours a night, which is kind of borderline. People think they're getting enough, but in fact they perform quite poorly as well.
They do, and they might have poorer memory, ability to express themselves. They might have poor sort of reaction time on simple tasks. Things like driving may not quite be as accurate. Some of the changes can be subtle. It's not that they're falling asleep all the time, but they're just generally not functioning well. They might feel they're a bit foggy. They might find their attention lapses easily. So they may not pick up on the signs of decreased alertness or tiredness. And often when these people improve their sleep, whether it's a medical condition or adequate duration, they suddenly realise, wow, I can be so much better. Because they get used to, of course, the poorer quality. So a lot of people think they're getting away with it, but they're not really. The changes can be subtle but important.
But I do want to talk about some of the sleep problems, but poor sleep can lead to a whole lot of health issues. What are some of those things that people should be concerned about? So
we've talked about some of the sort of cognitive impairments you get. Conditions like sleep apnea are associated with hypertension. They will cause hypertension if they're untreated and diagnosed. They'll increase your risk of heart attacks and strokes. They can contribute to insulin resistance and even diabetes. There's a higher mortality in some of the sleep apnea groups and even in some of the short and long sleepers. So in studies that have looked at sleep duration, people that sleep too little or too long have a higher mortality. Now, there may be various reasons for that, and there can be some confounders in the study, but that's statistically been shown in several studies. So there's a whole lot of manifestations of these sleep disorders, from mortality to vascular to metabolic problems to sort of more mental and concentration problems, and even, of course, things like driving.
Well, that's a topic I know you've done a lot of work on. But the other one that often surprises me is when I'm taking a history and people have been on antidepressants for so long, and yet no one has ever looked at the quality of sleep, which, I mean, if I don't sleep well for a week, I start to feel a little less, I feel a bit down. So that must be a huge problem as well.
Absolutely. So there's a big relationship between sleep disorders and mental health, increased risk of anxiety and depression, and people are more refractory to managing their anxiety and depression if their sleep is not controlled. So it's exactly like you say, if you're not sleeping well, you're feeling more irritated, more anxious, your ability to tolerate stress and to manage your mood is impaired, and of course you can have low energy and sleepiness, and that overlaps with the symptoms of depression too.
Now, I was reading another study recently about the link between poor sleep and dementia, because of this new system we've found, because they never used to think that the brain had a lymphatic system, that drained out all the waste products, but in fact they have found that it has, and sleep's a pretty important part of it.
Yeah, so there are studies coming through now to say that untreated sleep disorders are associated with a high risk of dementia. So that's early days, it's often association studies, but you can easily see the relationship between sleep and we've talked about just daytime function in terms of how people think and therefore dementia. And certainly already I'm starting to get lots of patients from neurologists or geriatricians to screen and assess for sleep disorders because they're demented or dementing or they've got early dementia. And you can imagine that when you're in that situation, these patients that are otherwise quite functioning, they're scared about their mental cognition, they'll do anything to get better and to stave off that dementia or to reduce the likelihood of it happening. So it's a real concern for patients when they think they're facing dementia because the doctor said, listen, you're starting to perform badly on these tests or there's a strong family history. They're really looking at their sleep as one way to improve how they can perform during the day.
Yeah. Now, you're a sleep physician. And a lot of people aren't familiar with a sleep physician. What was the journey, professional journey, that got you to this point?
Yeah, so sleep physicians are medical doctors. So obviously I did medicine. That's the basic medical degree.
Yep.
And then I did what's called physician training. So that's a specialty training where you end up as a sort of general consultant physician. You learn all aspects of medicine from cardiology to respiratory to gastroenterology. But then I subspecialised in sleep and respiratory disorders. So two subspecialties, but they're closely related because some of the sleep disorders are breathing disorders. And then I did a PhD in sleep medicine and then a postdoc overseas. So it's been a long journey to get where I am.
Yeah.
And as I tell my poor son who complains about studying for year 7, I said, you know what? When I finished year 12, I did 17 more years of study.
Oh, wow.
And then I was at the bottom.
Yeah. That was the beginning of your career.
Yeah.
That's where you started
17 years post-school. So a lot of time thinking about sleep.
Yes, yeah.
So I'm glad I enjoy it.
But now you did your PhD in the connection between accidents, and wasn't that right?
Correct, yeah.
Yeah, tell us a bit about that.
So the PhD was in the prevalence and the effects of obstructive sleep apnea in commercial drivers, truck drivers.
Right.
And it was based around the Australian transport industry, which is obviously a big area in terms of driver fatigue. Transport drivers and truck drivers in particular, they tend to be middle-aged, overweight male. I'm speaking statistically from the studies, and that's got associated a much higher prevalence of obstructive sleep apnea, and hence they're more likely to have driver fatigue and fall asleep road accidents, just from the sleep apnea perspective. So the study looked at how common that was and what the implications were, and with a view to try to treat these people, in fact.
Now, we're going to talk again about some of these sleep disorders, but for people who are wanting to get a good night's sleep, what would be your top, I don't know, how many, 6, 8 or 5 or 3 top tips about getting a better night's sleep?
Yeah, look, it's tricky, but look, I think the first thing is just to recognise sleep as an issue. Start to understand the importance of sleep. It's just the awareness that we need to make time and respect sleep. So respect your bedtime, respect your sleep time. So the number 1 tip would be allow enough time for sleep and don't let other things intrude on that time, including technology, for instance. The second issue, I guess bigger issue, is if you are having a lot of troubles with sleep, difficulty falling asleep or feel like you get adequate hours but you're still tired and sleepy during the day, go and seek help because there may well be a genuine sleep disorder in there that needs to be addressed. So both of those tips, if you like, are around awareness and understanding that there can be issues. But on a simpler perspective, you need to create an environment that's conducive to sleep. You need to have your bedroom free of distractions. It's not a general work activity area where you've got your computers and you're listening to music for long periods and you're listening to podcasts all the whole night in bed, as good as they are. It needs to be a place of rest where your mind learns to associate the bed with sleep and it's more likely to fall asleep. You need to make sure that it's private, that you've got light and noise, outside noise controlled. Generally, you want a lower temperature in your room. You don't want it to be too hot in order to help you drift off to sleep. You want to think about things like exercise. We generally think morning exercise is most conducive to good sleep at night time. Some people can get away with exercise late in the evenings and it doesn't interfere with sleep, but many others will find that if they exercise too late, it raises their metabolic rate, it raises their temperature, and it's harder to wind down and fall asleep. I think people need to allow themselves a bit of a wind down routine or a wind down time at least where they've stopped doing other more alerting activities, whether it's work-related or other family-related, and they've just got half an hour where it's starting to set the scene for sleep. Mm-hmm. So there's probably a whole lot of little things in there that people need to consider. It's all about just respecting and understanding that sleep is important.
Yeah, great. Look, we're going to get you back and talk about some of these sleep disordered breathing conditions that you mentioned, but it's given our listeners a good appreciation of what I think we started this with, and that is that we think sleep is the most important part of the day. So thank you.
No problems. Thanks, Ron.
So I think we've covered some really interesting stories about the basics of sleep, what a consistently good night's sleep is. And in our practice, and I think this is three questions that obviously are very important to be asking on a regular basis. We do that. In our practice, we're not only checking whether people are brushing or flossing, we are a dental practice, but we also ask them these three questions. And they are, is it easy for you to fall asleep at night? Yes or no? Do you wake up through the night? Yes or no? And often people will tell us that they wake up to go to the bathroom, and there is a surprising link here between getting up at night to go to the bathroom and how well you breathe while you're asleep. And finally, and most importantly, we ask the question, do you wake up feeling refreshed? So they're the key questions. And I think, as I said to you at the beginning of the podcast, my own story, I had been snoring for years, snoring in my 40s, and I'd always dismissed it as my wife's problems, not my own, and it became a bit of a joke until she said to me that it had got so bad that I actually had to move out of the bedroom. And so her problem suddenly became my problem, and I really never considered myself as sleeping badly at all. I just snored. So I actually did something about it, and what I did about it was got a mandibular advancement splint. It's a plate that fits in the mouth, and there are all sorts of ways of treating snoring. This is one of them, and so I got this splint, and some amazing things happened. Firstly, I stopped snoring, which was great because I regained my place in the bedroom, which was a great relief to me. But more importantly, just as importantly, I guess, I suddenly realised what a good night's sleep was. For years, I just assumed this was the way it was and this is how I slept. But after I stopped snoring, meaning my airway wasn't being blocked by my jaw and tongue dropping back to the back of the mouth, I thought, wow, I actually have had a great night's sleep and I have got so much more energy. And there's no doubt I've got enough energy to do all the things I'm doing. So that was the really big breakthrough moment for me. But of course, if you accept that sleeping is the most important part of the day for a person's health, and if you are fortunate enough to be sharing a bed with somebody who you love and care for, and you care for their health, then your snoring is not something to be dismissed. And what happened, apart from the fact that I stopped snoring and I felt better, was my wife had unbroken sleep and she felt better, and she was just a lot healthier and happier for that. So that's something that I wanted to share with you as a story. Now, the other thing is we're going to talk a little bit about sleep studies, but in this next section, we're going to go into some of the problems that can occur when you're not sleeping well. Welcome back, Anup.
Thank you.
We spoke last time about sleep being the most important part of the day and covered some basics, but we mentioned also some sleep-disordered breathing conditions, and I know one of them is snoring, which a lot of people just dismiss as, oh, that's a bit of a joke, it's her problem, not mine. Can you tell us what the significance of that and other sleep-disordered breathing conditions are?
Sure, thanks, Ron. Look, there are many sleep disorders, and often the focus is just on conditions like snoring and even breathing disorders. But it is important to realise there's a whole range of conditions, and we may talk about some of them today. But essentially, snoring is obviously a noise issue, and it affects relationship and it affects partner dynamics. But it's also an important clue that there may be a serious narrowing of the airway that's causing health problems. So snoring is a symptom of obstructive sleep apnea. With snoring, there's partial narrowing of the airway to create turbulent airflow and vibration and the noise of snoring. But with obstructive sleep apnea, the airway closes off completely in sleep. So there's a fine line between a narrow airway that's snoring and a completely blocked airway, which is sleep apnea. And if you have this completely blocked airway or sleep apnea, your brain has to wake you up to rebreathe. So people end up with disturbed sleep quality, they end up with tiredness and sleepiness, and they can end up with a whole lot of long-term health outcomes like blood pressure, increased risk of heart attacks and strokes, increased risk of arrhythmias, diabetes, and even higher mortality. So snoring is a clue that you could actually be having obstructive sleep apnea. Not everyone that snores has sleep apnea, but it's certainly one of the cardinal symptoms, and it's a clue that patients may well need further investigation to rule out or treat sleep apnea in order to improve how they feel during the day and also their long-term health.
REM, rapid eye movement, non-rapid eye movement. When people snore or have obstructive sleep apnea, do they go into those deeper levels of sleep?
They generally do, but in the severe cases they may lose REM sleep or find they've got less of it or a lot more broken REM sleep.
Right.
And that's because in REM sleep the muscles are most relaxed and you're most likely to block your airway. So in really severe breathing disorder cases, people just lose REM or the REM's delayed, and then when you put them on treatment we see what's called a REM rebound. So if we do a repeat sleep study on treatment, we see suddenly all their REM sleep reappears.
Right. Now, just to remind our listeners that the REM was when we almost become paralysed. We're only breathing from the diaphragm. All our other muscles go slack.
Correct, yeah.
So
and we
that's
think
the
it's
rapid
one of the deeper and more important stages of sleep, particularly for things like memory. Correct, yeah.
Now, you mention there are other sleep disordered breathing conditions. We talk a lot about snoring and obstructive sleep apnea or OSA. Just touch on some of the other things. I mean, how big a problem is this?
Sure. So we've got central sleep apnea, which is a condition where people also stop breathing in their sleep, but it's not because their throat blocks off, it's because there's no drive for breathing. They just don't make the effort to breathe. So with obstructive sleep apnea, the airway blocks off behind the tongue, and they're still trying to breathe. With central sleep apnea, they're not even trying to breathe. Now, people with heart failure, people with strokes, people on certain medications, high altitude, there are various conditions that cause central sleep apnea. And that in itself can cause poor quality sleep with brain arousals and tiredness and sleepiness. It's an important differential of obstructive sleep apnea and needs to be considered in the way we treat sleep apnea. So that's another big breathing disorder. But the other one that's worth talking about is hypoventilation. So
that's
less ventilation. Yeah.
Hypoventilation. Yeah, go on.
So some people, when they're asleep, just don't breathe enough. So they're not blocking their airway. They're still trying to breathe, so they've got that drive, but they're just underventilating or underbreathing. And it might happen because someone's very overweight. It might happen because of a medication. It might happen because they've got some sort of chest wall or structural deformity that limits the mechanics of breathing. So there's a whole lot of different conditions that can also cause that, and that in itself is disturbing. It can cause poor quality, tiredness, but it can also lead to heart failure, what we call right heart failure. You start to put a strain on the heart because of the underventilation, and that then leads to fluid retention and all sorts of long-term health outcomes. So there's a range of different sleep disorders, and there's a few others that we won't go into.
Right.
But essentially, it is important to know what type of breathing disorder is going on and to treat it appropriately.
And it's not necessarily, I mean, the archetypal, as you mentioned last time we spoke, the archetypal obstructive sleep apnea person is an overweight, middle-aged man, but it doesn't have to be that way, does it? I mean, I've seen I'm sure you've seen many more than I have, young women who are not overweight, or even children.
Absolutely, yeah. So it is classically thought of as middle-aged overweight male, but you're absolutely right. There are other patient groups. So there's also the postmenopausal woman in particular is a classic sleep, or perimenopausal, postmenopausal woman is a classic sleep apnea scenario. And that relates to the way the sex hormones change around that time, the body fat distribution changes, and they just have this increased tendency for obstructive sleep apnea. But the other big group is the craniofacial abnormalities that predispose to obstructive sleep apnea. So we see this particularly in certain families or in Southeast Asians, where they have a narrower airway due to the way their jaw and their mandible in particular is located and positioned. And that leads to a narrow airway through bony structure and the increased tendency to block off. So we see higher levels of obstructive sleep apnea in the Southeast Asian group in particular at lower levels of obesity. And I'm sure that's a group that you would see a lot too. And that can be a really hard group to treat because they're often younger, presenting with symptoms, signs and a diagnosis of sleep apnea. And it's largely due to sort of bony structure. It's not a weight-dependent thing for which they could work on.
Well, you know, in our practice, one of the things that I've observed for years is that 95% of the population don't have enough room for all of the 32 teeth we've evolved to have, which means they've got a lot of people are out there with very narrow or crowded teeth or narrow jaws, and that means they've got a narrow upper airway. So they're kind of predisposed to it, particularly when you factor in the modern lifestyle we lead.
Correct.
So it's an issue, isn't it? That's kind
it's
of part
an issue, and it's very common. That's the thing.
Now, when you're referred to a sleep physician, you often will be referred for a sleep study. Can you tell us what a sleep study is and what it measures?
Okay, so a sleep study is basically measuring the quality of a person's sleep with particular reference often to breathing. So we put in what we call EEG leads or electroencephalogram leads on the brain, so we can actually see the brain waves and determine whether they're asleep or not, and the stages of sleep that we talked about before.
Because in the deeper levels of sleep, their brain waves reflect that deeper level of sleep.
Correct. It has a different pattern to it. And we actually at the same time measure their eye movement, so we can see very easily if it's rapid eye movement sleep versus non-rapid eye movement sleep, and also how much sleep's going on. So that's a really key aspect of a sleep study, those brain waves and the eye movements. We also measure breathing, measured by a little cannula in the nose, also by bands across the chest, so we can see the distinction between airflow and effort. We look at oxygen levels, we look at body position, we do a heart rate monitor, we often do a leg sensor to look for leg movements. So there's a whole lot of physiological different recording leads that we put on a patient to measure how much sleep, what the quality of sleep is, and whether there's breathing disturbances in particular affecting that. We can literally measure every single breath, and we can see if it gets blocked, and then the exact effect of that on the brain. Does your brain wake up, for instance?
Yeah.
We can see what position it is. We can see what happens to the oxygen level. So it's an incredible amount of data, incredible detailed data, in fact.
And from that, if it's obstructive sleep apnea, it's often categorised as either mild, moderate or severe. We talked about a patient who gets too much sleep, and I know I had a patient recently when I asked her, how do you sleep at night? She said, oh, Ron, not a problem. I can sleep anywhere, anytime. I sleep 12 hours a day. Sleep is not a problem. I'm just chronically tired.
Right.
This was her own statement. So actually not getting enough sleep is one thing, but getting too much sleep and still being tired is another, isn't it?
Absolutely, yeah. So that's an interesting description, because she's obviously just doesn't get the fact that she's sleeping too much, and that in itself is a problem. If a person sleeps 12 to 16 hours a day, they may think they're fine, but clearly that is a disorder, if you like. And we have names for these conditions too. So a lot of people find that very disruptive, of course, because they can't do anything else. So they will come and we will diagnose various sleep conditions perhaps in that situation. But to sleep that amount and still be tired, of course, does raise the possibility that there's a condition that's disturbing the quality of the sleep as well. So no matter how much sleep they get, the quality is still poor, and hence they're tired the next day.
Which is the airway? Which
could easily be the airway, yeah. But I think that case really just demonstrates how little people understand about sleep. If they think that is just okay.
Yes. Well, I get patients come in to me for chronic fatigue thinking they need their amalgams out, and some of them may well need that out. But when I asked that question, and I remember actually, now you may not remember this, Anup, because Anup and I have worked together for several years. So we have shared some patients, and I did send her to you, and she ended up with an AHI index, which was about... Well, explain the AHI index.
So that's your measure of sleep apnea. So that's basically the number of blocked airway events per hour of sleep.
So either restricted or completely blocked.
Yes, Okay. So it doesn't have to completely block for us to think it's important, because even just the almost closures cause brain arousals and drops in oxygen levels.
Well, she had, and I mean, just to put it in perspective, what is the measure? If you have 5 to 15 of those episodes an hour, an hour, then that's mild. And if you have 15 to 30 episodes of obstruction or restriction, that's moderate. And over 30 is severe. She had 58.
Wow.
So that's quite...
There you go.
Even though they're only 60 minutes in an hour, I don't know when she was breathing.
Exactly.
But that was incredible.
She's not. Every minute she's blocking, and remember, we don't even rate a blocked airway until it happens for more than 10 seconds.
10 seconds,
And the average duration is probably closer to 20. So for a third of the night, she's just not breathing.
What's the longest you've ever recorded anybody actually stopping breathing?
To be honest, it can be 2 minutes and even beyond, probably about 2.5 minutes. So it's staggering, because if you held your breath underwater for 2.5 minutes, you'd just pass out and die. So there seems to be a little bit of tolerance at night time for stopping breathing, in the sense that you don't die, or at least we don't think you die.
We can't
show that you die at that point, but clearly it has a lot of other effects, which is what we've talked about before.
What are some of the things people can then do when they are diagnosed with say, obstructive sleep apnea, be it mild, moderate or severe? What are some of the things they can do?
So if it's weight related, we certainly recommend losing weight. So that's a key for many people for lots of health reasons, not just sleep apnea, blood pressure, cholesterol, diabetes risk, heart disease risk, stroke risk. So losing weight can be an important strategy. As you know, for some of the milder end of the spectrum, we recommend mouth splints, so particular mouth guards that sit over the top and bottom teeth that connect and push the lower jaw forward, and that helps to open up the space behind the tongue, and that keeps the airway open to reduce snoring and sleep apnea. There are some surgical procedures also designed at opening up the airway, whether it's concentrating more on the nasal airway or the area behind the tongue. There is a Cpap machine, which is a machine by the side of the bed.
So CPAP stands for?
Continuous positive airway pressure.
Right. So it's actually pumping, literally putting air in there to keep the balloon open or the airway open.
Correct, yeah. It's putting pressurised air in that sort of acts like a splint, a pneumatic splint, to keep the airway open.
Right.
It's very effective. We tend to use it more for the moderate to severe end. It can have remarkable benefit, but of course the problem is not everyone finds it easy to use.
What is the compliance rate on CPAP machines? I mean, what percentage of people that get prescribed it use it regularly for a whole night?
Yeah, look, a lot of it depends, I think, on how symptomatic they are and what benefit they get. So the ones that are significantly tired and sleepy often do quite well because they perceive the benefit and they feel brighter and better, and they're able to do a lot more during the day. So they're often quite compliant. At the end of the day, like lots of medical treatment, compliance drops off. I mean, even compliance with like cholesterol tablets drops off, hypertensive tablets drops off. And probably around 40% might give it up. Right. At a guess. It just depends on which group, severity group, and where you catch them in the cycle. Compliance is a limiting factor.
Now, last time we spoke on about insomnia, and I just want to finish with a little bit of information. It was a big problem. I mean, you mentioned it could be anywhere from 20 to 40%. This is chronic insomnia, which again, define that for us. What would define a chronic insomnia?
So that's difficulty going to sleep or maintaining sleep when people are waking up too much overnight or can't get back to sleep. And then during the day, they're feeling tired or drowsy or irritable and disturbed by their sleep quality.
But it goes on, it needs to go. I mean, we all have periods of that, but where it becomes a chronic problem, it's more than a month?
So it needs to go on for at least a month and at least several nights a week.
Yeah. And you also mentioned that there were different types of insomnia. There was the ones about couldn't get to sleep,
which is sleep initiation insomnia.
Yeah,
and then we talked about sleep maintenance insomnia, where people wake up, can't get back to sleep.
Yes.
And then we talked about early morning awakening, where they just sleep right through and then wake up at 4 a.m. and just can't drift off again.
Yeah. And last time we spoke, you did mention a few things that people should. Obviously, looking at sleep hygiene, the sleep protocol that people put on it is a really important part. What are some other strategies that people can do? How does one treat insomnia?
Yeah. So those general sleep hygiene principles, I think, are good for just everyone at all times, and it's a helpful start for the insomnia patients, but they're not that powerful for the insomnia patients at the end of the day. So then the insomnia patients need to be treated with either what we call cognitive behavioural therapy, which is changes in routines and habits and sort of mentation about sleep, or with medications, or possibly with a combination of both. The important thing about medications for insomnia is they should really only be used in the short term. And what most people need is the cognitive behavioural therapy. That's a bit of a challenge because a lot of people can't access it, or it's not even offered by many doctors. But hopefully with time, these things will be increasingly available and also accessible through some online programs that are starting to be developed. But essentially what cognitive behavioural therapy does, it's a whole structured program delivered by psychologists, just like you might do it for depression or anxiety, usually over several weeks, maybe months, on a handful of occasions. And they're basically reteaching people how to sleep and giving them good sleep techniques. So it's a lot more advanced than sleep hygiene. They might try to set some rules about how they approach the bed and what they do in bed. It may look at giving them distraction techniques or relaxation techniques or breathing techniques for when they can't fall asleep. It might even use a bit of mindfulness, maybe a bit of meditation. And it might also be designed to address some of the cognitive side, the way people think about sleep. Often people with chronic insomnia start to fear the bed and don't want to go to bed. and start to develop all these sort of maladaptive thoughts or behaviours. And it's about trying to recognise what they are at a patient level, turn them around and deal with them. So it's really quite a complicated condition with time. Insomnia really becomes quite burdensome and quite a few facets that keep it going. And that's why we need a sleep psychologist, with good training experience delivering what we call cognitive behavioural therapy.
And I guess calling a program as sleep the most important part of the day and you're not sleeping would add to the anxiety there.
That's right.
But anyway, thank you so much for joining me again today. We've covered over these 2 programs some really important stuff on sleep, and I hope everyone has got the message that sleep is the most important part of the day. Thanks, Anup.
No problems. Thanks, Ron.
So there it is, folks. Sleep is the most important part of the day. Don't ignore it, particularly if you're chronically tired. And from my own experience, as I said, I never thought I had a sleep problem, but in fact, and actually when I had my sleep study done, I didn't seem to have a sleep problem. I didn't register as having obstructive sleep apnea, mild, moderate or severe, but I did snore and I still felt much better for it. So just because you don't have an identifiable disease, you can always improve your sleep. But don't get too stressed about sleep. I have done another great podcast. This is going to be a recurring theme on this podcast. You're going to have a listen to this great chat I had in coming weeks with Dr. Chris Winter, who's written a fabulous book. So we're not finished with this topic yet. It's far too important. So until next time, be well. This podcast provides general information and discussion about medicine, health and related subjects. The content is not intended and should not be construed as medical advice or as a substitute for care by a qualified medical practitioner. If you or any other person has a medical concern, he or she should consult with an appropriately qualified medical practitioner. Guests who speak in this podcast